meeting to order then. It's October 22nd. It is, let me make sure we're okay on the time. Yes, it's 3:02 p.m. We'll go ahead and begin. We have an agenda in your packet. Are there any additions or changes to the agenda?
I believe we approve the agenda as presented.
I second it.
Okay. We have a motion and a second. All in favor say aye.
Aye.
Opposed the same. Actually, that's unanimous. Sorry. You also have minutes of the previous meeting, I believe, or were those in the email? Those must have been in the email.
No,
They're in the packet also. You didn't get them?
I don't think I have the minutes either.
Okay.
I think we have the monitoring report, is that an executive summary?
Okay, I'm gonna
Yeah.
make copies.
I looked at this last night, they may be in here, I overlooked them, but I don't see them.
They're in the board packet.
Yeah, they're in the board here. Why don't you just take these?
Yeah.
So if you want to take just a
The last paper clip.
minute to,
Yeah, it's the last grouping.
Start at the back, the very back of the packet, the last paper clip. Yep, take that, that's it. There you go. Yep.
so if you want to take just a moment to look those over. Billy, did you have those?
Did everyone get them in the mail too as well?
No.
They must not have.
Yeah, I got those yesterday. They came yesterday.
And you got the minutes in your packet?
No, I don't see
No,
them.
yeah.
What did I do?
Don't know.
Okay.
Well,
I thought I had them online, but I'm not certain.
no, they are only posted online once they're approved, because then they're considered official documentation.
I don't see a copy here in my.
Mary, where are they in this,
They're the second page after the agenda. In the last.
It was the very last paper clip.
Okay.
I don't think you went far enough down in the packet.
They're right here.
right here? Okay.
Did you, in the essence of time?
There, flip it over, there you go.
Okay.
Since Billy doesn't seem to have those either, would there be any objection to tabling approval of the minutes to next meeting, or is there anything in here that we need today?
I don't think there's anything that you need
Yeah, right.
today.
Okay. Billy, would that be okay with you if we just table that since you don't?
Yeah, that'd be fine.
Okay.
That'd be fine. I don't see a copy in my package either, so.
Okay. We'll table those until next month's
That
meeting.
sounds good, Michael.
Okay, the next item on the agenda are the monthly reports. Ms. Sinclair, do you prefer to start with the performance improvement grid as listed here? Or?
Yes.
Okay.
Let's-
All right.
Okay, so
I'll
that's
let you lead off with that.
D1, this oblong spreadsheet. And I'm going to go into just a bit more detail for Jay. Does everybody know Jay, since this is his first meeting at this committee? We all know? Okay. But this is simply, I present this to the board because it's about our internal tracking of issues that we've, not necessarily that are discovered by oversight organizations, but that we discover ourselves. And so I just thought that if this is the board performance and quality committee, then they should know what we're tracking and trying to improve. So that is what this is. This is a group of all our own internal corrective actions that we're doing. Now this first set of actions on page 1 relate to the access to care report. We track them on here, Jay, for a period of 6 months if it's a monthly report, or 3 quarters if it's a quarterly report. And once we have achieved that measure for 3 quarters or 6 months, then we take it off the grid. if it is something that an action that we implement internally that has no measure, once we have verified that the corrective action has been implemented, then we take it off the grid, because there's no reason to keep it on because we're not measuring anything. And we have the access to care report on our agenda for later. You didn't get it in your packet, but I brought it today, so it's in the board packet today. And we can discuss unless you have any questions about anything on the grid.
Ed or Billy, are there any questions on the performance improvement grid?
No, I think it did look like, what was it, the health and safety was a little odd, but I guess it looks like it's actually focusing with all the other areas of hospitalization.
And the issue with that is the numbers are so small that when you have just one error or two errors, it really skews the percentage.
Right.
So you'll see that that if you
And then I assume this on the next one down, provider satisfaction survey. That's outside. That's done by Western Carolina University.
remember when we had the satisfaction survey done by the state, and it was immediately following the merger, and our results, we weren't very happy with them. So Brian had, we did our own survey,
Oh, good. Okay.
and Western Carolina, we contracted for another survey, and Western Carolina University did that for us.
Okay.
And we found some additional items, and when these things are, when the corrective actions are implemented, they'll be taken off.
Okay, that sounds good. I don't have any more on that performance good for this one.
Ms. Pat, do you have any questions?
No, I have a couple things I want to bring up at other business, but no, I don't think it's really hot.
About this?
Okay. All right. Then if we want to move on
To the monthly report,
to the report, yes.
which are the items 2A, 2B, and 2C. And Jay, this long, the legal size paper are September monthly figures. And then there's an executive summary that explains any trends. And then we have slide presentation of 12 months of performance. We again met or exceeded all the standards. We've done so for all of the standards for a period of at least 13 months. So not all these measures have standards, but for the ones that do, we have met or exceeded them.
On this,
claims, I need to, do you mind if I, for the claims, for Medicaid only, which is the third page, you'll see that it went from 178,000 to 86,000. The reason for that is that the definition, DMA's definition of a claim changed. And we used to count claim lines, so a claim would come in and it might have 1 or 2 or 3 lines, like 3 different services, and we would pay for each of those 3 different services. But now we pay for only the header. Now we count only the header on that claim, and so that's why it's almost cut in half. It's because there are usually 1, 2, or 3 lines to a claim header. So now instead of counting lines, we're counting the actual claim, and that's where the change in numbers has occurred for that measure.
when you're talking about community psychiatric hospitalization, And I know this is probably not a hospital that a lot of our providers refer to, but in Sunday's paper, there was a huge, huge story about Park Ridge Hospital. And one thing that concerns me, and I don't know how many of you read it, how many of you heard about it, but I urge you to read it and read it good. They have 2 locked units at Park Ridge. It's my understanding they have a senior unit or Alzheimer's unit, and they have a psychiatric unit. And it seemed like what I got out of the paper article, and it was all about Medicare and Medicaid fraud, or a whole lot, or billing wrong, and ordering services that probably really weren't or shouldn't have been that necessary, plus huge fees for people working 3 or 4 days a month, maybe making $300,000 or $400,000 a year or more. My question is this, are we the payers, if they are Medicaid clients to that hospital, for the psychiatric patients that are locked up there? Because, I wonder how many got locked up that could have been treated in the community there, if that's just their way of business, is ordering expensive services that may not be necessary.
We are Medicaid payers for Park Ridge. We do have a contract with them for their psychiatric unit.
And is anybody looking at that, and how can we,
We do monitor our claims, yes.
well, is anybody monitoring the situation after all this big story broke? And how many may be locked up that shouldn't have been locked up to begin with over there?
Well, there are 2 different,
But to
Two
me,
different
it
issues.
seems like things may all tie into one.
right, but one of the issues is medical necessity, and those services need to be authorized, and so we do not pay for them unless we authorize them. And if we authorize them, that means that the care management department has looked over the records and the request and determined that the stay is medically necessary. That's one thing. Now, whether treatments, when they're in there, specific treatments, we pay only a daily bundled rate, so it's a little different for us. If they're there, we just pay a flat rate for the day, and then anything that they provide, it has to be covered by that rate. But you're right, they did have a big, most of it was Medicare, I think,
Well, the whistleblower,
settlement with DOJ. Do you know anything more specifically
I mean, the
about it?
whistleblower
Because I read about
$5
it.
million apiece, 3 whistleblowers
Yeah,
that
it was
work
a
there.
key tam, it was, yes.
It's bad.
I read that article, and that's about all I know.
A few weeks ago.
Yeah, it's a couple
Yeah, I
weeks
didn't read
ago.
the most recent one.
Well, the Sunday paper
Yeah, it was on the.
was horrendous, and I read it in Haywood County at a Bojangles about 9 o'clock at night. And I went Monday looking for a Sunday paper and found one at a grocery store that hadn't sold them all, and read it twice, and I'm sitting there going,
It's very disturbing, yes.
it's horrible.
And I am no longer involved in program integrity or investigations, so I can't tell you whether we, hey,
Hey, that was really good today.
Well,
whether, but I will follow up.
can I make a recommendation from this committee or from me that program integrity or somebody look at my concerns, or this
Yes,
committee look
I will
at?
follow up with the Senior Director of Contract Performance and Special Investigations and ask her if, based on those findings, we are doing an investigation of our own, okay?
Thank you.
Thank you, Pat, for being so conscientious.
Well, in my world, consumers get exploited a lot. I've recently been exploited for $500 more for something I was getting some work done on, and they gave me one price, and they said, oh no, we're gonna up the price in the middle, and you're gonna pay $500 more. So, it just, but now this was in the millions and millions, and it was Medicare and Medicaid. But we don't really have anywhere to go to, so I'm glad this kind of thing's coming out. Because, if I sign up to get some care, whether it be medical or dental or whatever, and somebody gives me a price, I'll sit down and think, well, is this what I can afford? And then if in the middle of it they say, oh, we're going to charge you $500 more just because we can, and we've upped our bills for everybody else. Don't matter what we told you a year ago, then you just, basically, you paid $500 more, or the $8,000, which happened to me a year or two ago with something else. So it's ugly, and I want all this to come out.
think we were looking at
Nice to
the
see
monthly
you.
monitoring.
Thank you.
We're in the monthly data.
Monthly monitoring report, which is the long sheets here with,
Second page.
Billy, do you have any questions on the monthly monitoring report?
We didn't seem to change much from last month that I saw.
Um,
We'll have a high penetration rate, and that's good.
Grievances went down.
Well, which report is it that has suicides on it? Do we have one of those?
There is the critical incident review report, and that's the one that we've talked about in the past, that suicides are probably misrepresented because medical examiners are err on the side of caution, and for a lot of overdoses, they put accidental death, and we don't know how many of those might be intentional suicide, but that's, I don't have the schedule with me.
That would be another thing I'd want to bring up. It's been on the
Well,
news that
incidents-
suicides among teenagers in
We have our
our
incident
state have
incident
increased
report summary, so
either
we'll
by
look
a
at that.
third or by double.
We'll look at that shortly, the incident report summary, in the quarterly data. It's not a monthly report.
Are there any other questions on the monthly monitoring report?
I don't know if this is known, but it looks like, no, okay. The thing looks like the admissions, the inpatient admissions, and the number of days are down, the number of people are down, but the length of stay is longer. I mean, it looks like that would be statistically significant. Is there anything that you look at could account for that? It's on the second page.
So the optimism in me wants to say that the right people are getting to the hospital
Yeah,
instead
yeah,
of those
of
people who
course.
have short in and out stays.
Uh-huh.
But that would be my,
I mean, even the length of stay for substance abuse is longer. But has there been any concerted effort or is there anything that you can point to that says that something's been done to make admissions more appropriate and length of stay longer?
actually, there is a quality improvement
Huh.
project. It's called the Admit and Rapid Readmit Project for hospitals, and it's looking, it may have had some impact on this because it's looking at the appropriateness of admissions and readmissions, just like we are with the emergency departments.
Yeah.
So they're doing that for inpatient also, and it shows here our ED admits are down a bit,
Mm-hmm.
and in our project with the 5 comprehensive providers, all of theirs who are active consumers are down. So it looks like what they're doing may be having some impact on the ED visits.
That's really interesting. Yeah, that's actually helpful. It would be good to this is the kind of stuff that if we had somebody to do a research project, look at it, and do the statistical analysis and report it.
Well, I actually did hire, we now have a provider quality initiative specialist, and he really likes statistical analysis. So, and he's on this project now, so maybe he'll spin some numbers for us.
Yeah, that's really great.
But I did see, I've been in a meeting all day, but I did glance at an email that he had written me and said, good news, 4 out of the 5 comprehensives have significant drops in their ED visits, and the 5th one is coming down more slowly, but is moving in the downward direction.
Yeah, that's great. You know, I mean, this is for the future, but we do have the approved state funding, they have the state funding to create a new program, residency program in psychiatry for the region. So this is the kind of stuff that residents can look at. You know, they need to do scholarly work. They could actually work with Smokey, publish this kind of stuff. This would be terrific, so it's something to look forward to.
And my guess about the length of stay for substance abuse is that those are probably individuals who have dual diagnoses.
Most certainly.
And so that they're actually staying in there longer than it takes to get detoxed or have their substance issues addressed and getting some, like medication stabilization type
Right.
services.
Right. I mean, these are the kind of things,
Guesses.
I mean, these are the kind of things that Smokey really needs to be able to show that having an LME is valuable to the community. That's valuable because you can institute broad-reaching programs that have a more comprehensive scope and actually get outcomes in areas that we need outcomes, relevant outcomes. That is a relevant outcome if it's true, if that trend increases, and that's terrific.
Any other questions on the monthly monitoring report? If not, we'll move on to the quarterly reports.
So which one is going to now?
The quarter,
Okay,
quarterly reports, it should be E1.
right.
This is the grievance summary. If you read that executive summary, if you've read it at the beginning, it'll explain some of the things that you may see in the, when you look at the numbers.
Are there any questions on,
Yeah, I'm just curious to separate out how many grievances were filed by one grievance. I'm looking through it.
just a moment in case anyone else has any questions?
So you have a team that handles the grievances, or do they go before committee, or how does that work?
There, in our quality management unit, there is a grievance team. It consists of a grievance manager and 2 grievance specialists, and they respond to all of the grievances. I think we have one out there that's taken longer than 30 days to resolve. Let's see. Okay, we have a couple. So this most recent Q1. So we're doing pretty well. Generally, when it takes outside of 30 days, it's usually a communication problem with the provider, getting back and forth and getting our resolution worksheet filled out. But
Looks like mental health only or up a little. And of course, developmental disabilities, but on this page 6.
Look at page
So
7.
on page 7, we're going up 36 from the previous quarter, 17, is that one person in non-grievances, or?
it could be, that could be included in that, yes. And actually, I believe that is included in that number against Smokey. They were against Smokey and not against a provider.
And hopefully the next quarter that'll drop back down.
I hope so. Whenever we do trend analysis, both for Smokey and for providers, and try to address anything that is more than just a one-off type grievance. We address them all individually, but if it looks systemic, then we will address it systemically also.
And you read over all those yourself, don't you, Julie?
The letters, yes.
Now, if I'm reading this wrong, that matter, but looking at table 3 on page 3, with the increase in access to services complaints as well as quality of service complaints, then when you flip over to table 9 on page 9, it appears to me, on at least casual plans, that the ACT teams as well as care coordination, one of which would be a provider and one of which would be Smokey, resulting in a fairly high
increase.
Right, the,
percentage of that. So is there a connection then between the types of complaints increasing in access and quality with those numbers?
with the ACT, we have one particular ACT provider that has received several complaints. Actually, I think we have two now, I don't know if that we have sent for investigation with our contract performance and special investigation, and that would be about the quality of services. The care coordination increase has to do, my best recollection, with multiple issues regarding a specific case.
So in other words, there are more than one complaint on the same case, is that what you're saying?
Yes.
Okay.
Is that fairly common, Julie?
No,
Intensive in-homes received a little more.
well, now, I think that maybe some of those for intensive in-home, what's gone back up to 4, some of those that I've read have to do with intensive in-home being taken out of some of the contracts.
So you really can't tell if it was bad service or service not provided.
Correct. Not from these numbers.
On page 10, psychiatric services went from a 1 to a 9. What's going on, Rick and there?
I don't know. It doesn't appear, she would have put something on the front page if there were any trend. It may, my guess would be that that is an issue of access to services because we,
That would be my guess too. Just guess.
I know that we've had, I've read recently several letters about people having trouble seeing a prescriber.
You need one particular location or just in general?
In general.
In terms of the one case that you were referring to that had the multiple complaints, has there been a resolution to that particular situation?
My understanding, yes and no. Part of the issue has been resolved and part of it has not.
I guess the question would be, is there a reason for us to be concerned? Is it ongoing, you know,
We are working on it, yes. It's not systemic, so I don't know that there's a need for board concern.
When, looking on table 10, page 12, we got a pretty good number in some ways that are out of catchment area. Are these out of state or just out of the 23 counties, or are they both?
There are 2 down there, Pat. There is an out-of-state.
Oh, okay.
The out-of-state are generally youths who are PRTFs out of
Right,
state.
so it's not as bad as just the out of catchment.
Yeah, catchment would be, foster children who need services who are like in the east, and if they have a grievance and they have Medicaid in one of our counties, or if they have a complaint, or if somebody has a complaint about one of our providers and their Medicaid is out of one of our counties, it's either of those 2.
How are
That
these?
could be just across the state line or the county line, or it could be across somewhere else. Right?
Yes.
I had a question about page 13. I was wondering why Buncombe County's percentage of grievances is higher than everywhere else.
Actually, Alexander's even higher.
Yeah.
Swain.
Wow.
Rutherford?
Numbers are, you know,
I think you have the counties that are higher are where you see, more services being provided.
Okay, so different services that may not be available in other counties.
I don't know that.
Okay. I guess just keep watching this trend and see if nothing still keeps being higher than all these other counties.
And what I can do is, while we were looking at this, I, actually, if you'd like, can request that the grievance manager attend the next time we have this quarterly report, if you like.
That
So,
might be good because we do seem to have questions for him that might help us understand this a little better.
well, maybe rest of January, I'm gonna be on the phone and,
Stephanie Hotfinger.
so these counties where we have huge percentages, like Alexander and Buncombe, we could have multiple grievances from the same person in these totals, is that correct?
We could, but if you look at Buncombe County, we have a lot more providers in Buncombe County and a lot more people get services.
Oh, I didn't notice it.
No, that's right, I didn't see that Alexander was high too, so.
Didn't notice it before, but I'm noticing it now. Between page 13 and 14.
Well,
What
I
is
don't
the-
even have 14, so.
Excuse me, 12 and 13.
Oh, okay.
12 and 13, I apologize. If you look using Buncombe as example, they're listing 42 as the number of complaints, whereas, oh, wait a minute, one is,
Where the provider's located, and one is where the person's Medicaid originates, or where they live.
yeah, so, yeah, now I see the difference.
Say that again,
So on page 12,
where the provider's located.
yes.
Okay.
And on page 13, it's where the, either the Medicaid county of origin or the residence of the person, their county of residence.
That makes sense.
Would the number being served in Buncombe County be so much higher because there are inpatient hospital beds in this county, or?
I think there's just more people.
Okay. Well, I know there are more people, but I just wondered if the fact that there are hospitals and stuff here too, that people typically from other areas end up in.
I don't think that would account for another good.
And really, it's kind of hard to tell without knowing the individual cause of grievance and stuff too. Let's really figure this out somewhat.
Yes.
Are there any other questions on the quarterly reports?
Well,
Grievance one?
Did we go over the estimates yet?
No, we haven't.
I'm sorry, the grievances is what I meant. Just getting ahead of
I'm
myself.
good with the grievances.
Okay.
Yeah.
Questions, okay.
No.
Then we'll move on to the incidents, which is E2. And that is the, chief of its like, it's like everybody's got it, okay. Any questions on any of this information?
These incident reports, are they provided by the providers?
Yes.
Okay.
When you're talking about restrictive intervention, it would be interesting to know what different counties and areas have the most restrictive interventions.
County of provider or county of individual?
Where the service was provided, I guess. Whether it be group home, private home,
So,
uh,
so you're not asking about the county, you're asking about the facility type?
I guess it would just be
Yeah.
interesting to find out where we stood. I mean, there's some counties that provide more services, such as the counties that have hospitals and stuff, that have psychiatric units, such as here in Nashville. Over here, the hospital's been in the news a lot in Henderson County. It would be interesting to see how the restrictive interventions across the board from place to place compared. If one place was having a lot more than the others, or if they're all pretty well even, or, you know, if there's some particular, because to me, 324 restrictive interventions looks kind of high. Maybe I'm wrong, but, and
Pat, what page are you on?
I'm on page 2, the incident report summary.
Okay.
And it's 324
In
level 2.
a year? That's in a year?
Well,
Mm-hmm.
so,
Okay. So you want to know the types of facilities broken down?
I guess,
break it down by
and
the
my
types
other
of
question is, if we are the payer for services at these different places, then the restrictive interventions should come through here if they do any, and should be able to be countable. Is that correct?
If they report it.
Do
Yes.
they have a duty to report it?
Yes.
Okay.
We actually sort of have the answer to the question, because on page 4, that breaks it down by, this is the same data, right? I mean, we're
Yes.
talking about a fiscal year on page 4 and a fiscal year on,
I guess what I'm
Page
concerned
2.
about is, you know, like I said earlier in the meeting, reading the Park Ridge article, I just wonder how many people got put in one of those locked units simply as a way they do business. So I guess I'm just looking and a little more finely, and wish it was a little more spread out and detailed. So if there is a problem, it's boom, right in my face.
of
Well,
course,
now
Park
we
Ridge
have-
was also Medicare,
yes,
which is not something we manage.
But a lot of it in the article was Medicaid too.
we have somebody that looks at each and every one of these incidents, including the restrictive interventions, and they track and trend. They just give a summary report to us. And if there is a provider that has a trend up of something, including restrictive interventions, then it's referred to the Contract Performance and Special Investigation Department to look at. So we do track the trends internally.
Am I correct in terms of categories? Park Ridge would be in the PRTF category, is that right?
No,
No.
that's a specific service for adolescents. Park Ridge is community psychiatric hospital.
And so in terms of, if you look at those top 10 services, 40 is the lowest number in there, but they're hard none from that type of facility, correct? I
For
mean,
the,
in the
you
top
are
10,
on page
4.
4?
right. In other words,
So-
she's asking about Park
You
Ridge
know, yeah,
and
that,
wondering if there's a connection between
So for
the
the,
numbers on page 2.
Yes.
So if there were a connection, we would see
right,
a number of incidents here, would we not?
yes, you would
Being
see
high.
hospitals mentioned.
I just have to honestly wonder
But
if things are
hospitals,
even getting reported that
hospitals
should be.
do not have a requirement to submit incidents to us.
Okay.
How can we
So it-
fix that?
Well, federal law. Would be federal law.
So I need to send the article to SAMHSA and say, this needs to be looked at and this needs to be fixed.
Well, or your,
Congressman,
yes.
I mean, maybe you already discussed it, but the big issue in the Park Ridge settlement was not related to anything. I mean, the biggest part was just the Stark violations, just the inerrant activities for the physicians, overpayment of physicians. I mean, that was
huge.
what it was all about.
But, you know, well, yeah, for me, I just feel like they just scratched the surface with what was in the newspaper. I don't know why, I just have this feeling.
Actually, the entire claim is public information.
Where did you go to find that?
I mean, it's, somebody sent it to me. I could send it if it would be helpful, but if it's, it's 108 pages. But, that's not atypical for any big claim like that. It was the claim, it wasn't the settlement, it was the claim.
Well, and I'm sorry, you know, as we sit here and I talk about them, John's daughter, who's been in a hospital in Marion for 2 weeks and is waiting for a transfer probably to a nursing home in Park Ridge area in Fletcher so she can go over there for 6 weeks every day to try to save her foot. So, my family uses Park Ridge. John, the VA refers clients to Park Ridge. Maybe that's why, it's a little more, I'm a little more concerned about it because at the same time that we're reading this, we got Nikki laying in a hospital bed in Marion and knowing that, she don't get the care she needs, she's probably going to come out of this minus a foot. And she's been there for a week and a half now, and frankly, ungodly, she's probably going to try to manipulate the system after the first of the month so she gets paid her SSI before the nursing home gets her. It's just, I wouldn't believe that these people that are just trying to live on the edge, things they go through, and things sometimes they put their families through. I went shopping for her at 10 o'clock last night for underwear to take to the hospital because we thought she was going to be transferred today. But, I bought her $60-something worth of clothes, so she had decent clothes at the place. But it's just, and I told her, go. If it'll save your foot, don't worry about the press. You need to do,
The other thing is, when something like that comes out, just like what the grievances say about smoking, if it's a problem with one piece, doesn't mean everything's bad. So there are quality things going on,
but
and there are oversights, things that aren't monitored well enough everywhere. And it's unfortunate that people practice that way, but I don't know that in any case you can generalize.
But at the same time, she's got physical issues and she's got mental issues. And she's used them for both, but it's just sad.
I believe we have one more in the quality reports, the access to care, is that right?
We do, and that one was not, it got put into the board packet, so don't look in the one that was mailed to you, please look at the board packet. The access to care.
It would be in the very, very back.
It looks like this, yes. Has, once again, we struggle because the standard that is set is higher than industry standard. We struggle because these measures are dependent, now, not so much the emergency ones, but an urgent appointment is scheduled within 48 hours of your call. A routine appointment is scheduled within 14 days of the request. We schedule 100% of the appointments within the appropriate time frames. I want to make that clear. Everyone gets an appointment. The problem is assisting people in keeping the appointments, and we do make reminder calls for every individual who schedules an appointment through us, and we make follow-up calls to ensure that if they didn't attend their appointment, that they still need one, that they get another one. We do have a quality improvement project that our customer services is working on to try to get these numbers up. But again, we are being measured on something that's dependent upon other people's behaviors, and that's very difficult. Because if I call and I feel like I'm in crisis, and 2 days later I feel better and I don't want to go through the hassle of going to an appointment, then that's my right, because I need to do that. But that, so this number may relate to some of that.
What was the previous month's?
The previous quarters are actually on that, on
On the
this,
follow-ups?
on this,
Oh, and then one new.
right, because we struggle with this.
It shows up.
Yes, we
Yeah.
struggle. We're getting better on the emergent, but.
Well, I want to say this, I'm tickled to death that the number referred to 911 for safety and medical reasons is not way up there. Because sometimes that can be the worst thing you can do. If they don't want the police showing up at their door, if they call in and they want to go be seen, give them the choice to walk in voluntarily.
It looks like it's not substantially different, but from the previous quarter.
No, in fact,
It might, one of the things that makes this more meaningful, if you have a no-show rate or a do not keep appointment,
I think we
in primary
can
care,
probably
we
do that.
follow do not show rates. I mean, even for primary care, it can be as high as 15 to 16%. But, that would change the interpretation of these numbers.
okay. We can, this is the report that we give to the state, and we can augment it, with
Yeah.
those numbers. And in fact, I'll see if I can bring that back next meeting.
Because it wouldn't be nearly as meaningful just to know, it is important how many, when the follow-up is, presumably, because if you don't follow up, you don't get the treatment, you end up in crisis care again, but at the same time, if there's a no-show rate of 30%, well, that's really different. That means there's certainly effort going on, appointments were made, but didn't keep.
I can do that.
Any other questions on the access to care report?
No, I don't have it.
Yeah, I'm sorry, Billy. Is there any other business that we need to take care of before we conclude the meeting?
I do have one follow-up from the last meeting. I was asked how long our recordings of the customer services calls were kept, and our policy is to keep them for 60 days. They don't roll off in 60 days. We keep them for longer, but our policy is 60 days.
I'm trying to remember who requested everything.
I did.
Okay.
I think there was something about a recorded, listening to a recording of a call, and some measure in there, and Pat asked.
There's another follow-up that didn't come out last time, but I think maybe the time before, or the time before that is, there was some discussion about why there was, that there wasn't internal consistencies amongst the LMEs regarding some of the metrics that were being recorded. And we had the person from the state that was here, and there's going to be some effort to try to create some internal consistency.
That is this access to care report. I think it was that one.
Well, but there was a statewide comparison of all the LMEs, and maybe that was, I think one of the metrics was the access to care, but there was also utilization of services and emergencies and hospitalizations, and what we understood is that there were not consistency in how those metrics were reported. But has there been any?
Well, that's, okay. There is a consistency in how those metrics are required to be reported.
But not how they're measured, not the definitions.
Some LME MCOs call out certain things before they measure the data.
Yeah, just the methodology of how it's done.
And the requirements and the requirements for what goes in the numerator and what goes in the denominator are clearly outlined. So there is no reason that they should not be reported the same way.
Do you all meet? You're being very polite. So good. You were right.
I agree.
You were very correct. So, do you all meet with each, meet around the quality? And does this ever come up?
We meet monthly. The quality management directors meet monthly and discuss the measures, and everybody reports that they are following the requirements to submit the measures. The problem with that meeting now is not all the LME MCOs belong to the North Carolina Council of Community Programs, which is where those forums take place. And so now not everybody is involved in those discussions.
Right.
But everyone on the QM Directors Forum, they report that they are submitting the measures, these monthly measures, as they are defined.
Right. But not using the same methodology. So it's hard to, so what's the reality is then it's hard to compare the relative success in meeting those metrics from LME to LME.
Right, and we have to compare ourselves to ourselves.
Yeah. More over time rather than across the state. It's too bad, really, because it is a way, I mean, it's a nice, that's a great methodology for improvement. Not in a punitive way as much, but just as a way of saying, how can we do better if nobody likes to be at the bottom. And everybody likes to be at the top.
Now you notice we were at the bottom of the consumer satisfaction survey year before last, and this year we're at the top.
Yeah.
So we had 3 or 4 measures that we were under. They're on the performance improvement grid. I believe it was 4 measures where we were under the average, but all of the other measures we were above average, and a lot of times we ranked first in consumer satisfaction. So that it looks like, and I'm going to say, that our corrective actions that we put in place did have some impact.
Yeah. I mean, so I don't mean to beat a dead horse on this, but is there any place for having a sort of independent or outside research firm or even a university take that on as a project of trying to standardize the methodology across the state?
Now, we do have an external quality review every year, each LME MCO by the same organization. For the past years that we've been in business, it's been Carolina Center for Medical Excellence. And when they come out and do their external quality review, they look at policies and procedures, but they also look at the code. for performance measures
Right.
and determined that it is written the correct way for the measures.
Mhm.
And if they find an error, then we require a plan of correction. So everybody is showing their code, and I mean, if they, I don't know the results of other MCOs, external quality reviews. I know this past time we had some difficulty with our code with Alpha, and we had to get them to change
Mhm.
some things. If that were going to be done, it would have to be done through DMA. They're
Yeah.
now doing an RFP for a new organization to do that, too.
Yeah.
And then we go,
Yeah, I mean, one of the things that's really interesting to me is how the state allocates resources for major problems. And this recent sort of emphasis by the president on problems with substance abuse, as an example, it would be nice if you knew, like, the counties where there was the biggest problem with substance abuse, and you could actually direct resources selectively to counties. You know, it's almost, you know, like the Shep Center puts out data on where the manpower shortages are in terms of healthcare delivery. And you know, the counties are rated as tiers. And some of our funding agencies, like the Golden Leaf and KP Reynolds, I mean, if you're not a tier 1 county, you're probably not going to get any, you're not going to be eligible for any funding. But if you are, you know, if you're a high-risk county, you're just much more likely to get resources to direct to help the problem. And if the state could do that also.
we actually, I don't know, has the board seen the gaps analysis and needs assessment yet? Maybe we see it.
I want to say yes.
Because, I mean, the provider community saw it in September, and that is our own look at our 23 counties to see where the needs are most prevalent and where there are gaps. We do surveys about that. And that might be and then of course we do our network development plan based on that. And we are in the process of planning our next gaps analysis. We're just starting that process. If there's something that you would like to suggest to be included in that, I can give you the person who's in charge of that. I can
You know,
do that.
yeah, I would like that actually.
His name is Tommy Duncan,
Oh, okay.
and I'll give you, I don't want his phone number recorded, I'll give it to you off.
Okay. Okay.
I was going to say, if we adjourn, I can turn it off.
Are there any other business items before we adjourn? If not, we'll stay adjourned until next month.
Thank you.